when we ended the class, this chart was there. See, in this chart, for the sympathetic nervous system, receptors are described for different actions. We'll come to the actions. Receptors are described. Can you see alpha, beta? Like here it is written M. Okay. Can you see these are the receptors? But they are written only in this chart. They are written only for the sympathetic nervous system. So just going into a bit of it, receptors will be there for both sympathetic and parasympathetic nervous system as well as somatic nervous system. Anywhere where a neurotransmitter will act, any neurotransmitter will act, there must be receptors. So what we did not mention yesterday, that here what is the neurotransmitter? Somatic nervous system, acetylcholine. In parasympathetic preganglionic neurons, acetylcholine. Just look and say, but this should be clear. You will not get time to study this further. Just do it in the class itself. Acetylcholine is the neurotransmitter in most cases, whatever you discuss. Somatic nervous system, acetylcholine. Motor neuron, neuromuscular junction. Nerve physiology, which was done in the beginning of the year. Not in the beginning, in the middle of the year. Nerve muscle physiology, neuromuscular junction, it is acetylcholine. For parasympathetic preganglionic neurons, it's acetylcholine. For parasympathetic postganglionic neurons, it's acetylcholine. That means parasympathetic system, acetylcholine. Somatic system, acetylcholine. Sympathetic system, preganglionic, acetylcholine. Postganglionic, norepinephrine. Okay, these are the neurotransmitters. What is the exception in case of sympathetic where it is acetylcholine? Sweat glands and some blood vessels in skeletal muscles, but prominent example is sweat glands. Okay. Now receptors, wherever acetylcholine will be acting, the term used is cholinergic. Wherever norepinephrine is acting, the term used is adrenergic. Now there are receptors. Adrenergic receptors are of broadly of two types, alpha and beta, which is mentioned is this chart. See, lot of alpha and betas. Now what is M then? Capital M in two cases. See, in case of sweat glands, there is a capital M. Capital M stands for one type of cholinergic receptor. Adrenergic receptor are of broadly two types, alpha and beta. Alpha and beta is again subclassified into alpha is of two types, subtypes, alpha 1, alpha 2. Beta is of three subtypes. Beta 1 till date, these types have been established. Beta 1, beta 2, beta 3. Science is an that means ever developing area. In science, you can't tell tomorrow another receptor can't be classified. Till now, alpha 1, alpha 2, beta 1, beta 2, beta 3 for adrenergic receptors. For cholinergic, its capital M is muscarinic, stands for muscarinic. You don't have to write anything now, these things are all in the books. And there is another subtype, that is N. N is for nicotinic. These are all named after some chemicals which were found to react at those receptors, Muscarinic is from muscarine. All these are alkaloids from plants. Nicotinic is from nicotine. So parasympathetic, not parasympathetic, cholinergic receptors are of two types. Now which of the statements is true? Parasympathetic receptors are all cholinergic. True or false? Parasympathetic are all cholinergic, be it preganglionic or postganglionic. True. All cholinergic receptors are parasympathetic. No, because like in case of sweat glands, it is cholinergic but sympathetic. So just orient these things in your mind, which will help you to tackle MCQs as well. When you read one topic, whenever we read one topic, we'll come back to MCQs later. No, we will prepare, try to think what MCQs can be there, what explain whys can be there. Okay, because from the exam point of view, from the knowledge point of view, it's okay. You have to know the things and apply. From the exam point of view, questions are long questions, broad questions 15 marks, then 10 marks questions, then short note types of questions, explain why type of questions, and MCQs. These are the 5 categories. So you have to think like that. So receptor types again, alpha 1, alpha 2, beta 1, beta 2, beta 3 adrenergic. nicotinic and muscarinic for cholinergic. Inside nicotinic, there are subtype of nicotinic. See a subscript after N and a subscript, both are nicotinic. NN and NM. This second N and M are subscripts written just below. These are called subscripts. To avoid confusion, because this M sometimes, mainly for the beginners, mostly for the beginners, you can M. This M is not for muscarinic. Muscarinic is single M. To avoid confusion, even standard some authors are also writing N1 and N2. Okay. NN and NM, these are two subtypes of nicotinic receptors. Nicotinic is not mentioned here, where they act, how they act. Not how, but why, where they act, we are saying. Just coming to it. Somatic nervous system, acetylcholine, cholinergic. So receptor must be among these three, NN, NM or muscarinic. So there the receptor is one subtype of N1. Cholinergic. N and M can be there where there are cholinergic. These are cholinergic receptors. So here it is N1, here see acetylcholine. It is preganglionic. What is this part? Post parasympathetic preganglionic, right? This is the cell body of the preganglionic neuron in the CNS. This is the preganglionic neuron itself. It is synapsing with the postganglionic neuron at the ganglion itself. That here the receptor is nicotinic but different from what is there in the somatic nervous system. In the preganglionic neurons and in the, see there is one synapse in the adrenal medulla. All these are nicotinic, but those in the preganglionic autonomic neurons are different from the somatic nervous system. One is N1, one is N2, or NN and NM. To avoid confusion, say N1 and N2. And where there will be cholinergic receptors and the postganglionic neurons, it is muscarinic type, right? Muscarinic type. Earlier in the first year, the teachers did not used to go into much details. Okay, but now there are MCQs in a professional course. You cannot say this was not in the syllabus like this. So sometimes they are setting some difficult MCQs also. So just know some things which will not harm you. And all these things are required when you study about the drugs in pharmacology. Nicotinic, muscarinic, adrenergic, where alpha 1 is acting, not required so much now, but it will be required when you study the drugs next year after passing the first MBBS, first prof. So here it is one subtype of N. In preganglionic, it is another subtype of N. Preganglionic means both parasympathetic and sympathetic. But where there will be acetylcholine, cholinergic in the effector organs, that means postganglionic neuron, acetylcholine is acting, it is muscarinic, M type, capital M type, not nicotinic, muscarinic. Where it is not adrenergic, it will be adrenergic receptor. Obviously, it will not be cholinergic, M or N. It will be adrenergic alpha or beta. Okay. Now, cholinergic sympathetic, where it is sweat glands, postganglionic. What will be the type of receptor? Muscarinic. Postganglionic cholinergic is muscarinic. Preganglionic cholinergic is nicotinic, but different from the nicotinic of somatic nervous system. And adrenergic is adrenergic. In the case of the adrenal medulla, there is no question of postganglionic neuron. The whatever chemicals are directly released into the blood and carried to the effector organ, so it is acting like a hormone. Because definition of hormone is, from the definition of hormone, substances released far off from the target organ, usually far off from the target organ and carried by the blood. Here it is carried by the blood, so there is no question of neuron, postganglionic neuron, but as the system is looking same, preganglionic neuron is there, but it will not call be preganglionic neuron, because when there is a ganglion, proper ganglion, preganglionic, postganglionic. Here it is the adrenal medulla, but one explain why type of question comes. Adrenal medulla is a modified ganglion. Explain why. Adrenal medulla may also be called a modified ganglion. You have to tell it from the concept of the autonomic nervous system, right? So this is the basic structure. Now we discussed about these things. We are coming back to it. See the different functions. In case of the eyes, radial muscles of iris, okay, is under the control of sympathetic nervous system for dilatation of the pupil, and for constriction of the pupil, you already have done this clinical aspect of cranial nerves. Constriction of the pupil is by sphincter pupillae, controlled by which muscle? Sphincter pupillae, controlled by, still now, third nerve. So why it is called third nerve? It is parasympathetic system, because these nerves, parasympathetic nerves, are accompanying the or controlled by the third nerve nucleus, which is the Edinger-Westphal nucleus. Again, I will suggest remember the names of these 4 nuclei. 4 nuclei for the 3rd, 7th, 9th and 10th nerves, which will be giving, that means from where the parasympathetic nerves will arise and reach their respective ganglion. Names of the nuclei, names of the nuclei and names of the this ganglia. What are the nuclei? Third nerve, Edinger-Westphal nucleus. Ganglion is ciliary ganglion. Muscles are ciliary muscle and sphincter pupillae. You will get it in books. Whichever books you study, you will get it. For 7th nerve, superior salivatory nucleus and 2 ganglia, sphenopalatine ganglia and submandibular ganglia. Sphenopalatine ganglia, postganglionic neurons will go to lacrimal glands and nasal glands. Submandibular ganglia, postganglionic fibers will go to where? Sublingual and submandibular salivary glands. Okay. So in the clinics, in the clinical orientation, what was the orientation? Facial nerve supplies lacrimal gland. We talked about the Sharma's test for lacrimation and salivation. We cannot taste separately because it is also from the parotid gland. So we cannot taste separately, but sublingual, submandibular glands, parasympathetic fibers from the facial nerve nucleus. Superior preganglionic up to the ganglion. Which ganglion? Submandibular ganglion. For glossopharyngeal nerve, preganglionic fibers from the inferior salivatory nucleus to the otic ganglion, and postganglionic fibers from the otic ganglion to the parotid glands. Parotid gland is supplied by glossopharyngeal nerve. Okay, in glossopharyngeal there is a P. So remember P for P, parotid. Parotid is by glossopharyngeal. Rest to salivary glands are from facial. 10th nerve, huge discussion. I think some discussion is there in anatomy. Vagus nerve, you remember at least 2 nuclei, dorsal motor nucleus of vagus and nucleus ambiguous, and preganglionic fibers are going to unnamed nuclei near the thoracic and abdominal viscera, heart, lungs, spleen, etc. Pancreas, maybe small intestine, stomach. Okay. So these are, and see, preganglionic fibers are long. As you can see from this picture also depicted, preganglionic fibers are long because the ganglion is situated in parasympathetic system almost near the effector organ. Sometimes inside. In case of the eyes, it is like inside the organ. Okay, the ganglion. So postganglionic neurons are very short. Some explain why type of questions may be set here also. Okay, postganglionic neurons are very short or just MCQ type of questions. So these are the, remember these. Now what are the actions in sympathetic system? See, sympathetic system, there is a sympathetic chain we discussed. Sympathetic chain is composed of the paravertebral fibers which are lying near the vertebra. Ganglia near the vertebra. Paravertebral fibers. Preganglionic fibers arising from the thoracic and lumbar part. So it is sympathetic division of the autonomic nervous system is also called the thoracolumbar division, and parasympathetic division is also called the craniosacral division, because the fibers are preganglionic fibers arising either from these 4 nuclei. This is the brain, or the sacral region of the spinal cord. From the sacral region of the spinal cord, they are distributed to some these organs, colon, bladder. Okay, that means the lower part of the abdomen and reproductive male sex organs, female sex organs distributed through the pelvic nerves. So either the brain or the sacral region of the spinal cord, parasympathetic system. So it is called the craniosacral division. Sympathetic system, thoracolumbar division. Fibers are coming either to same level ganglia or to other levels also. There are no preganglionic fibers arising from the cervical region, but see, ganglion are there in the cervical level. Superior cervical ganglion, middle cervical ganglion, all these are there. So those fibers are traveling from the thoracic region upwards. Okay, then postganglionic fibers, which are labeled in blue here, are going to the organs. Okay, or the effector organs. These are in blue. See the sweat glands. From the sweat glands, these are in red, because that is for sweat glands is an exception where it is cholinergic, sympathetic but cholinergic, but still sympathetic. It is not parasympathetic. Cholinergic but sympathetic. Important exception. We are repeating. So you don't have to remember everything in this chart, and these types of charts are also given in the books you follow, but you don't have to remember everything. It is difficult. Just some things in the eyes you already know what is happening from your clinics classes also. Sphincter muscles of iris on contraction, contracting the pupil, ciliary muscles of iris, accommodation. Okay, you already know this accommodation by creating anterior bulge in the lens under the control of parasympathetic nervous system. Now some authors are writing radial muscles, ciliary muscle is relaxing under sympathetic division. Better say sympathetic division has no role. If there is a MCQ, sometimes there are confusing MCQs where there will be sympathetic division is responsible for relaxing the ciliary muscle, or it has no action. Better go for no action. But if in the MCQ there is only relaxation, then go for it. But between relaxation and no action on radial muscle, on ciliary muscle, if you have to choose, sympathetic nervous system has no action on ciliary muscle. Contraction of the ciliary muscle, contraction, relaxation reflexly, which is again this decreasing the anterior curvature of the lens. For the heart, everything, atrial contractility, conduction, velocity, heart rate, all these will decrease under the action of the parasympathetic system. Which nerve, which cranial nerve? Just we saw vagus, dorsal nuclear, motor nucleus and nucleus ambiguous, vagus. So what is the action of vagus nerve? Sometimes in clinics there, what is the action of vagus nerve on the heart? Vagus nerve on the heart, important. Action of vagus nerve, it will decrease everything. Heart rate, atrial contractility, conduction, velocity, all these are different. Conduction, velocity, contractility, that means power of contraction, and heart rate itself, rate, all these will decrease parasympathetic system. What will be the postganglionic neurotransmitter? What will be the neurotransmitter in case of postganglionic neuron? Vagus nerve, heart. Will it be? It can be two, acetylcholine or norepinephrine. So it will be acetylcholine, parasympathetic. Everything is acetylcholine. And heart rate increases, contractility, conduction, velocity, all increase under the action of sympathetic nervous system. What will be the neurotransmitter? Norepinephrine, adrenergic, sympathetic adrenergic, except sweat glands and some skeletal muscle blood vessels, but remember sweat glands. To simplify, remember sweat glands. Otherwise, where there will be sympathetic, it will be adrenergic. Any organ they mention, you say adrenergic. And receptors, so will be alpha, beta. Sympathetic, but see, M is mentioned. M means muscarinic. Only see skeletal muscle, blood vessels and sweat glands. Sympathetic, but M, muscarinic, because it is cholinergic. Cholinergic means neurotransmitter is acetylcholine. Nicotinic and muscarinic receptors were so named. Nicotine acts on nicotinic receptors. Muscarine acts on muscarinic receptors. Nicotine will not act on muscarinic receptors. Muscarine will not act on nicotinic receptors. But inside the body, that means in vivo, it is always acetylcholine. Acts on both types of cholinergic receptors, nicotinic and muscarinic. In the bronchial muscles, parasympathetic will cause contraction, that means constriction, bronchial muscles. So, if parasympathetic is overactivated, what will happen? Respiratory distress or relief? Distress or relief? Simple. Understand simply. Contraction, constriction of the bronchus, respiratory distress, parasympathetic. Sympathetic, it will be relief. So, there is something called sympathomimetics. Sympathomimetics means drugs given from outside. These things you will come across in pharmacology. So, this knowledge, this understanding is important when you study the text. Sympathomimetics means mimetics, which are mimicking the what is inside the body we are giving from outside. Drugs given from outside which are mimicking the sympathetic role of the body. So, those drugs will relieve us from respiratory distress. Okay. One such drug is salbutamol. You may knew about this. Salbutamol, like this. So, sympathetic drugs, it will lead to dilatation of the airways, sympathetic system. So, parasympathetic is constriction, overactivation is harmful. Okay. Now, what will be the neurotransmitter in the two cases? Parasympathetic neurotransmitter is acetylcholine. That means at the postganglionic junction. If nothing is mentioned, you consider postganglionic. Sympathetic for the constriction of, for the dilatation of bronchioles, what is the neurotransmitter? Norepinephrine. Adrenergic receptors, sometimes they are alpha, sometimes they are beta. Don't go into the details now. See, in this case, it is beta 2. Beta 2. Where there is alpha, where there is muscarinic, also 3 types. M1, M2, M3. Okay. In GI system, it is M1. For the heart, it is M2. But don't go into the details now. Only few days are left for the exam. You will again read these things in pharmacology. If you answer well, they may ask, but no harm. If you can't say, but at least you have to say muscarinic, nicotinic, alpha and beta. Okay. Alpha, beta for non-adrenergic, muscarinic, nicotinic for adrenergic. Likewise, stomach and intestine, parasympathetic. Stomach, intestine, all GI secretions will be increased by parasympathetic. Neurotransmitter again, acetylcholine, receptor type muscarinic, postganglionic. At the postganglionic neuron, that means at the effector organ, muscarinic. And it is a bit complicated here in the sympathetic nervous system. Don't go for this. In the salivary glands, like this will become complicated if you go into details. Secretions will increase for the salivary glands in gate and sympathetic system. But the parasympathetic system, it is only just simply saliva. For the sympathetic system, it is more thick viscous secretion, like amylase secretion from salivary amylase. It is under the action of sympathetic nervous system. But both are secretions increasing. In case of GI, except the mouth, that means except the salivary glands, in the rest of the GI tract, sympathetic nervous system, parasympathetic nervous system, it is the opposite. So, don't go into such confusions, but remember basic things. For the eyes, one important question is micturition reflex. Already discussed in renal physiology, micturition reflex. Okay, there it is important. How is the bladder controlled? Micturition reflex short note comes. And what is the control of the bladder under the parasympathetic and sympathetic? So remember, secretions increase in GI tract. Secretions increase in GI tract. Salivary secretion, parotid gland, submandibular gland, sublingual glands, all these cranial nerves, 7th, 9th, you know from the knowledge of your clinical physiology also. So, remember, secretions are increasing. Likewise, parasympathetic will hold urine in the bladder or void. Think like increasing secretions. It will void. It will release. Just to remember, secretions are increasing in GI tract. In urinary tract, there will be no secretions. It is voiding. So, what will happen? Under the action of parasympathetic, detrusor muscle of the bladder will contract or relax. For voiding, contract, and sphincters will relax. In sympathetic, it is the opposite. Detrusor will be relaxed. If detrusor relaxes, it will help to hold the urine inside the bladder, and sphincters will be contracting. See, no need to don't worry, alpha 1, beta 2, everything. And here this will be obviously muscarinic receptors, M type. Parasympathetic, it will be M type. For contraction, relaxation of under the sympathetic system, detrusor, sphincter, whatever. Sphincter means the external urethral sphincter. So this is alpha or beta. Don't go into details now, which is alpha 1, which is beta 2, which is beta 1. Leave it. Alpha, beta, that means noradrenergic for sympathetic, muscarinic for cholinergic, muscarinic for parasympathetic. Detrusor will contract under sympathetic. Whatever will be required for voiding, parasympathetic will increase secretions in GI tract and release the urine in case of when acting on the bladder. So detrusor will have to contract for voiding. This is common sense. Detrusor will have to contract, sphincters will have to relax. That is under parasympathetic. Neurotransmitter is acetylcholine. Receptor subtype is muscarinic. Whether among muscarinic, leave it for now, M1, M2, M3. But for the heart, you can remember M2, M2. Heart is it comes into discussion every time. It comes more often than not. But just for, if you can't say M1 or M2 or M3, if you don't know, just know muscarinic. Parasympathetic postganglionic is muscarinic type of cholinergic receptor. Nicotinic will be in case of where parasympathetic, sympathetic, preganglionic and in somatic nervous system. That also the somatic nervous system and autonomic, it is different type of nicotinic. Leave the gallbladder and all. Okay, lacrimal gland secretion by the parasympathetic, which nerve? Facial nerve. Which ganglion? Sphenopalatine. Which nucleus? Superior salivatory nucleus. But nucleus is superior salivatory. Ganglion is sphenopalatine. For submandibular, sublingual glands, ganglion is submandibular. Okay. Now this is again not complex. If you understand, nothing is complex. They are shown: sympathetic preganglionic, sympathetic postganglionic, parasympathetic preganglionic, parasympathetic postganglionic in different colors. So 4 colors for sympathetic preganglionic, see in red. Preganglionic, these are also appearing red, but this is orange. These are showing in blue. Sympathetic postganglionic, parasympathetic postganglionic in green. Okay. So this is the most simple one for you here, but these types of diagrams are given in your books also. Don't go for studying every organ, particularly this function, this receptor, this. Remember, parasympathetic, somatic nervous system, nicotinic, only one synapse at the effector organ, or not synapse, neuromuscular junction at the effector organ. Somatic, 1 neuron, acetylcholine, type nicotinic, N1. For autonomic preganglionic, whether it is parasympathetic or sympathetic, it is again nicotinic, N2, or in the adrenal medulla, preganglionic. In adrenal medulla, it should not be called preganglionic because there is nothing called postganglionic, but that is N2. In parasympathetic postganglionic neuron, it is muscarinic, cholinergic. In sympathetic, mostly noradrenergic, and in 1 or 2 cases, it is cholinergic. Again, the receptor will be muscarinic. Whenever it is postganglionic, be it parasympathetic or sympathetic sweat glands, it is muscarinic. So these basic mistakes don't make, rest is okay. So this is what will happen on the uterus sympathetic nervous system, where there is written contraction or relaxation, leave it, it will confuse you. Just in blood vessels, constriction in some cases, sympathetic, but constriction, it may be constriction in some cases, in some cases it may be dilatation. Mostly dilatation predominates. Dilatation, this is due to metabolic autoregulation. Dilatation predominates. Blood vessels, but if it confuses you, leave it for now. It may be either constriction or dilatation, but in most cases dilatation predominates. See, constriction and dilatation written. In skeletal muscle arterioles, sympathetic will constrict, not that one is parasympathetic is constricting, sympathetic is dilating, no, all is under the action of sympathetic, but it will confuse you. At least you remember for the eyes, for the heart, for the urinary bladder, because micturition reflex will come as a short note in. There are the other nerves also. They are going from the higher centers. When you describe the micturition reflex, you have to describe about, not describe, you have to mention about the higher centers. Mention means just mention, nothing to describe, that these higher centers are controlling and controlled under the action of sympathetic or parasympathetic. When there is voiding, micturition reflex, obviously parasympathetic. Voiding is occurring under parasympathetic. And mention the events. Detrusor muscle is contracting, sphincters are relaxing. Okay, this was done. Now there are some control of the autonomic nervous system, which are the higher centers. Some you already know, the cranial nerve nuclei, those are controlling the to one extent the parasympathetic nervous system. Cranial nerve nuclei, which cranial nerve nuclei? 3, 7, 9 and 10. Okay, 3, 7, 9 and 10. Which are the mixed nerves? Which are the mixed cranial nerves? 5, 7, 9, 10. What are the clotting factors which are vitamin K dependent? 2, 7, 9, 10. Cranial nerve nuclei concerned with the parasympathetic nervous system are 3, 7, 9, 10. Only the first numbers are varying in these cases. 7, 9, 10 are common. Remember like this. Okay. Mixed cranial nerves 5, 7, 9, 10. Now you know the names, trigeminal and all, facial, glossopharyngeal, and 5, 7, 9, 10. Mixed cranial nerves. Vitamin K dependent clotting factors 2, 7, 9, 10. Name the clotting factors. You have to memorize the 13 clotting factors, name them. And cranial nerve nuclei associated with the parasympathetic nervous system 3, 7, 9, 10. 7, 9, 10 are common in all cases. These first numbers are different. Okay. So they are controlling. Now some higher centers in the brainstem, hypothalamus are controlling. Paraventricular, if you don't remember anything, remember most important in controlling this autonomic nervous system, there are so many nuclei in hypothalamus, paraventricular nuclei of hypothalamus. If you want to write it down, you may write it down, given in the books, but just for final, just for one glance revision, paraventricular nuclei of hypothalamus, most important in controlling autonomic nervous system. Now you know about some nucleus tractus solitarius. You should have heard these names if you have attended classes, read books. Respiratory system already discussed. Nucleus tractus solitarius. Okay. RVLM, rostral ventrolateral medullary fibers, medullary raphe fibers. All these came into most of these came into discussion during respiratory system. These are controlling the autonomic nervous system. Controlling, like, and there are specificity and non-specificity. Like RVLM, it is controlling the autonomic nervous system in such a way that sympathetic nervous system is controlled, but only those actions which are on the heart from the RVLM. That means heart rate increase. It will not affect the respiratory system, RVLM. But when medullary raphe fibers, there are serotonergic medullary raphe fibers. Serotonergic means serotonin is also a neurotransmitter. Here in autonomic nervous system, we are speaking mostly of acetylcholine and noradrenaline, but serotonin is also a neurotransmitter. Serotonergic neurons in medullary raphe, they are controlling again the sympathetic nervous system. But what is this? It is controlling many things together. So the actions of sympathetic nervous system are on so many organs. When control of the RVLM only on that part which is going to the heart, that means the actions will be on the heart isolatedly. Increased heart rate, other organs will not be affected that time when controlled by the RVLM. And how it is controlled? It is involuntary. Obviously, whole is this thing autonomic, involuntary. It is not under voluntary action. We cannot increase or decrease heart rate by voluntarily. So autonomic nervous system is totally involuntary. Under the discussion of autonomic nervous system also comes the enteric nervous system. Enteric nervous system is actually independent. Okay. Even now without inputs from CNS, it is supposed to act because it contains sensory neurons, interneurons and motor neurons within itself. Enteric is GI system, enteric nervous system. But it is aided by parasympathetic and sympathetic from the CNS. But it is supposed to act independently also. So it is like an independent nervous system. It is like even if the CNS was not there, enteric nervous system could act because it is controlling sensory neurons. For any neural pathway, it will be sensory neuron, interneuron and motor neuron. So that is present in the enteric nervous system. Okay. Now control of the autonomic nervous system, we again told these some regions which will get in the names you will get in the books. So these are but most important, remember, paraventricular nuclei of the hypothalamus and nuclei of these cranial nerves you already know. Which nuclei? 3, 7, 9, 10. Names are Edinger-Westphal nucleus. For 7th nerve it is superior salivatory nucleus. Okay, for ninth nerve it is inferior salivatory nucleus. For vagus nerve, 10th nerve it is dorsal motor nucleus of vagus and nucleus ambiguous. Okay. These 5 nuclei, phone nerves, 5 nuclei, and considered higher center for the control of parasympathetic nervous system, autonomic nervous system as a whole. What is flanking nerve? Abdominal nerves. So, sympathetic preganglionic fibers are not only going to paravertebral ganglion, some are going to prevertebral ganglion also. What are the prevertebral ganglion? Names: celiac, superior mesenteric, inferior mesenteric. Remember from the names of those arteries, which you have to study in anatomy. You have to study the branches. You need to study the branches in anatomy. Direct branches of abdominal aorta. Okay, celiac ganglion, superior mesenteric, inferior mesenteric. Okay. Then, according to the names of the arteries, are named the ganglion: celiac ganglion, superior mesenteric, inferior mesenteric, superior cervical ganglion. Now, don't try to remember which is for which organ. It will confuse you. Okay, just remember that exception: sweat glands, cholinergic, and all. This is the about the distribution of to the organs. In case of male reproductive organs, you may remember, okay, erection, male erection is by parasympathetic, but emission and ejaculation of semen is under the action of sympathetic. Again, neurotransmitter, in case of parasympathetic, it's cholinergic, receptor type is muscarinic. Sympathetic, it's adrenergic, receptor type means not subtype, it is adrenergic receptor. Alpha 1, alpha 2, beta 1, beta 2, beta 3, whatever, but it is adrenergic. Okay. Ejaculation under sympathetic, emission and ejaculation, erection, penile erection under parasympathetic. Okay. Now a bit about the reticular activating system. It is mentioned in the competency number: autonomic nervous system and reticular activating system. Reticular activating system, it is a interlaced fibers, some network of fibers in the brain stem, interlacing network of fibers in the brain stem, okay, which is concerned with the, it is supposed to maintain, the function is asked, maintain this, we are sensing these things, all these sensations, this consciousness of the cortex is maintained by the reticular activating system. There may be cholinergic neurons, monoaminergic. So there are so many types of neurotransmitters. Acetylcholine and adrenaline, noradrenaline, these are not the only neurotransmitters. Serotonin, okay, monoamines, these are neurotransmitters. Serotonergic neurons will be there in the CNS, monoaminergic neurons, histaminergic neurons, histamine. All these are important when you study pharmacology. All these, you have to study the drugs separately. Okay, which drugs are acting on serotonergic neurons, which drugs are acting on psychiatric, so all the psychiatric, the drugs which are antipsychotic drugs. So serotonergic, which are acting on histaminergic neurons. Some you already know. Antihistaminics you require for peptic ulcer disease. What type of receptors? Histaminic, H1 and H2. Peptic ulcer disease. For allergic diseases, running nose, a person is having running nose, you are prescribing, doctors are prescribing antihistaminics. Histaminergic neurons, serotonergic neurons, monoaminergic neurons, complex network. These neurons, some are arising from the hypothalamus also. They constitute this reticular activating system. Activating means activation, maintaining the cortex in a conscious state. From there, the neurons are passing to the thalamus, hypothalamus, brainstem, passing to the thalamus, nuclei of the thalamus. There are names: intralaminar, all these nuclei of the thalamus. From there to the cortex. Sensory pathways, some are directly. How do the sensory pathways go? You already know. By now, it should be at the tip of your mouth. Exams, from the exam point of view. Dorsal column, medial lemniscal pathway for touch, vibration, pressure. Some authors are saying from fine touch is all by this system, but crude touch by anterolateral spinothalamic tract. Lateral spinothalamic tract, pain, temperatures. Fibers going there directly means to the spinal cord, to the thalamus. through the somatosensory area of cortex. Now some neurons are diverging and getting these inputs from reticular activating system, because if the consciousness is not there, then how will we sense? This maintenance of consciousness is by reticular activating system. It is also called the ascending arousal system, because fibers are, we just mentioned, fibers are ascending. Hypothalamic fibers, histaminergic fibers in hypothalamus. So they are ascending to the thalamus. From the brainstem, interlacing network of fibers, they are ascending to the thalamus. This is reticular activating system, help in maintaining this awakened state of the cortex. This is also called the ascending arousal system, because the fibers we are discussing are going towards the cortex from the brainstem or the hypothalamus. So these are ascending, it is going up. So also called the ascending arousal system. Reticular activating system may come as a short note, okay. But this is given in the same competency as the autonomic nervous system, but this is a separate thing. So in the autonomic nervous system, we have discussed how the fibers are distributed, what are the receptors, what are the neurotransmitters, what are the receptors, okay. Even if you forget the subtype classification of receptors, at least you should be able to tell nicotinic, muscarinic, adrenergic, alpha and beta, okay. In pharmacology, you have to study in more detail, okay. Muscarinic, where M1, in case of heart it is M2, muscarinic M2, in case of GI tract it is M1, okay. पहले खाओ फिर दिल लगाओ. M1 is GI, M2 is, this is a very accepted mnemonic, पहले खाओ फिर दिल लगाओ बाकी सब बाद में. M1 is GI, M2 is heart, and most there are overlapping. CNS, in case of CNS control, M1, M2 all are coming, but M1, GI tract M1, heart M2. Even if you don't remember this for now, remember muscarinic, cholinergic for parasympathetic, sympathetic, postganglionic. Sympathetic cholinergic, only one example, sweat glands, and also some blood vessels in skeletal muscles. What will those do? Constrict or dilate? It may do both. Now don't go into such confusion. Dilatation predominates, but constriction of arterioles, venules, arteries, veins, all sympathetic system. Dilatation also by sympathetic system, not parasympathetic. But see, in what you remember for now are the simpler ones. In bronchial glands, constriction by parasympathetic, dilatation by sympathetic. In case of heart, decrease of everything, rate, contractility, conduction velocity by parasympathetic, increase by sympathetic. Decrease by parasympathetic. Which cranial nerve involved? Vagus. Those vagus nerve nucleus, this diagram. Okay. For the eyes, dilatation of pupil, sympathetic, muscle, radial muscle of iris, parasympathetic, constriction of pupil, and anterior curvature of lens increasing by ciliary muscle, parasympathetic. If in the MCQ it is given relaxation of the ciliary muscle, you get the option is such that relaxation of ciliary muscle by sympathetic, go for it. But if it is a better option, which is the better option here? No action of the sympathetic system on ciliary muscle. If you get the option no action, if you get both the options, if there are bad people like me setting MCQs, both the options, confusing the students. So you go for better option is no action. Sympathetic system, no action on ciliary muscle. But if that option is not there, then relaxation of the ciliary muscle. Some ambiguity is there in some areas. Now, as you have read the sympathetic, about the sympathetic chain in anatomy classes, you might have learnt about the Horner syndrome. One clinical aspect of this Horner syndrome. Horner syndrome is asked, as far as I know, Horner syndrome is asked both in anatomy and in physiology. Horner syndrome, name is again after the person who described it. Horner syndrome is sympathetic breakdown. Breakdown means sympathetic dysfunction. Horner syndrome are in the face, in the facial region. Meiosis, M-I-O-S-I-S. That means constriction of pupil. Okay. See, mydriasis. Mydriasis is dilatation of pupil. that is under sympathetic system. If it is not functioning, meiosis, ptosis. Here ptosis is due to superior tarsal muscle dysfunction. Okay, superior ptosis, meiosis and anhydrosis. Common clinical triad of Horner syndrome. Clinical triad is ptosis, meiosis and anhydrosis. That means sweating will be absent. Sweat glands under the action of, we are repeating it so many times, under the action of sympathetic and cholinergic. Sympathetic and cholinergic. Are you listening? শুনছো? আর পড়ার টাইম পাবে না, ক্লাসে এসে অন্য জিনিস পড়ছো পড়ো, এইগুলো আর পড়ার টাইম পাবে না, এখান থেকেই মনে রাখতে হবে। Sympathetic cholinergic, sweat glands. So sweat glands, anhydrosis, meiosis, ptosis, anhydrosis. Okay. So treatment is very symptomatic. You can't change this. How can it happen? Say there are, if you see this diagram looking a bit complex to you, but you understand this. See, there are the lungs. Here there are the postganglionic fibers. There is a lung tumor which is enlarging. It is pressing, mechanical obstruction of the fibers. Okay, there is a tumor somewhere in the CNS which are pressing the fibers. There are various causes, tumors or some mechanical obstruction in the CNS. For now, you remember like this: tumor in the lung. There is one tumor named Pankos tumor. Even if you don't remember for now, tumor. It is a lung tumor. Mechanical obstruction of these fibers. May go and cause Horner syndrome. Okay. Because mechanical obstruction to the sympathetic fiber, sympathetic dysfunction is occurring. Clinical triad is meiosis, ptosis, anhydrosis. Ptosis is due to superior tarsal muscle. We also know ptosis due to dysfunction of levator palpebrae superioris. Here it is due to superior tarsal muscle. Okay, dysfunction. Meiosis is due to action of sympathetic nervous system is dilating the pupil. Here the pupil will be constricted. This is Horner syndrome. There is one important area, organophosphate poisoning. You have to know about the drugs again in pharmacology. Organophosphate poisoning. What happens? There is an enzyme in the neuromuscular junction which is cholinesterase. Now it will affect, this cholinesterase is affected. Okay, what is happening? Organophosphates. Phosphor, it is forming organophosphates. These are poisons. Names are parathion, malathion. Organophosphates. The farmers get affected. Okay. Blood, in wires, blood gases were used, poisonous gases, soman, sarin, these were used, SOMN, soman, sarin. So these organophosphates now create a phosphorus bond with the enzyme. Enzyme is cholinesterase. What is cholinesterase doing? It is breaking down acetylcholine at the neuromuscular junction. Now if cholinesterase cannot act, acetylcholine will act more than required, and it will cause overactivity of what receptors are there at the effector organs, be it somatic or parasympathetic, postganglionic, muscarinic receptors. So it will cause overactivity of this cholinergic system, parasympathetic cholinergic system. What will happen? Excess secretions, excess salivation. Person will choke out because of his own saliva, his or her own saliva. Excess salivation, excess lacrimation. Okay, parasympathetic overactivity. And constriction of, in what will happen in bronchioles? Constriction or dilatation, parasympathetic constriction, severe respiratory distress. If not treated properly, it may be fatal. In due time, it may be fatal. Antagonists are given which are breaking this bond. After, within say about an hour or so, within minutes to hours, it may become irreversible. A process called, there is a process called aging. If you don't even remember that, you have to act before that. In most cases, you have to act before that. There are drugs, okay, pyridoxine and all. Somehow they are either breaking this bond, phosphate enzyme bond, or they are preventing this bond from occurring. This bond from occurring, if they have to prevent, you have to give the drug within, if you know already, 10 minutes, or even prophylactic. There are prophylactic drugs also. When people used to go to wars, they knew that the enemies may target these poisonous gases on them. So prophylactics were given, so that they created these not harmful, bond with cholinesterase, and cholinesterase was still able to act. But if cholinesterase activity is gone, if that process aging has occurred, some drugs will not respond. Then you have to break the bond between that phosphate and all. Even if you don't know the names of the drugs now, what you know is cholinesterase is inhibited, so acetylcholine action is getting required, more than required, acetylcholine action. So there will be cholinergic symptoms, increased secretions, bronchoconstriction. Okay, heart will not be able to pump properly, rate will decrease, contractility will decrease, pupillary, it will be under the parasympathetic system, pupillary constriction. Okay, pupillary constriction. If the person becomes unconscious, then involuntary voiding, parasympathetic system overactivity. What happens in mushroom poisoning? Same type of things, not due to cholinesterase inhibition, same type of things due to muscarinic overactivity. In most cases of mushroom poisoning, muscarinic overactivity at cholinergic muscarinic receptors. Okay, there is one type of mushroom, I just can't recall the name right now, where there is anti-muscarinic overactivity. Due to poisoning, you have to treat accordingly. Where there is muscarinic overactivity, you will get these symptoms. Okay, excess salivation, excess activation, bronchial constriction. But if there is anti-muscarinic type of symptoms, then you treat likewise. Okay, so Horner syndrome, at least you remember Horner syndrome and organophosphate poisoning. What is happening? There is a disease called multiple system atrophy. It is one disease which is involving not only autonomic nervous system, also features of Parkinsonism, cerebellar ataxia. You tested with the help of cerebellar ataxia, you test with the help of which test? Clinically, Romberg's test. Clinical cerebellar ataxia, Parkinsonism, autonomic nervous system dysfunctions together. It is called multiple system atrophy. So, one subtype of that is Shy-Drager syndrome. Okay, Shy-Drager syndrome. So, don't go into these things. Their autonomic activity, autonomic dysfunction predominates over those Parkinsonism features or most cases treatment are symptomatic. Whatever symptoms you get, you try to treat the symptoms. We always can't treat the cause. Okay, always can't treat means it is not still available. Treatment is still not available. Okay, Parkinsonism, how do we treat? Levodopa, carbidopa, these drugs. Parkinsonism already discussed, basal ganglia, dysfunction of basal ganglia, Parkinsonism. Autonomic dysfunction, say blood pressure increases. What will happen? Constriction of arterioles, blood pressure increases. You have to treat with antihypertensives, like this. At least in clinical application, autonomic nervous system, you remember Horner syndrome and organophosphate poisoning. Organophosphate poisoning is due to cholinesterase inhibition, and cholinesterase cannot act. Organophosphates, phosphorus enzyme bond is occurring. Cholinesterase cannot act. Acetylcholine is overactive. Cholinergic overactivity symptoms occur. And in Horner syndrome, meiosis, ptosis, and anhydrosis. Sometimes enophthalmos also. Sunken eyeball. Right? Treatment is symptomatic. So these are some clinical applications. I think basic structure and actions on some important organs you have got by now. Reticular activating system is ascending arousal system. Fibers in the brainstem, hypothalamus going to thalamus, then going to cortex, helping to maintain the awakened state. Okay, this is not in detail but in brief about autonomic nervous system and reticular activating system, 1 or 2 lines. So, 1 or 2 more topics left before the syllabus is completed, and you have an exam, third semester exam from 1st July, third internal assessment.
Actually, optic nerve itself, if you go, it is a small portion, but if you have to go the optic pathways and movement of the eyeball and everything, that it includes many things. But optic nerve to optic pathways and its relation, and its positioning in the brain, and at what level any lesion occurs, and the outcome is actually optic nerve a part of the optic nerve apart from optic pathway, you cannot separate. Now, optic nerve begins at optic disc blind spot where the fibers of the stratum opticum coverage. If you, just for your interest, I would say that you just download Gray's Anatomy and see a section plus section of the eyeball and it is a histological section, the optic pathway picture and its total relation in the brain. But I would just, for your own interest, if you a casual look at the Gray's Anatomy's the total eyeball with the optic disc and optic nerve, and it's a histological section. And now pierces the outer layers of retina, choroid and laminar fibrosa sclerae at posterior part of the eyeball 3 millimeters to the nasal side of its posterior pole. During its passage through the tunics of the eye, it acquires myelin sheath. This is important. Optic nerve passes backwards and medially through posterior part of the orbital cavity and optic canal and joins with the optic chiasma in cranial cavity. When I told you the sphenoid, I demonstrated and I showed you the picture of the horseman or jockey on the saddle. Now, you just see, try to recollect the optic orbital cavity and the optic canal and joins with the optic chiasma in the cranial cavity. Now, intraocular part, optic papillae and optic disc. Now, the optic nerve head and see the retina, choroid, sclera. The previous slide showed you the description. Now, this is the surface nerve, 4 fibers, perilaminar region and laminar fibrosa region and retrolaminar region. Now, this is retina, choroid and sclera. Now, the intraorbital part, you see the total, the superior rectus muscle, the optic nerve is here. The ciliary ganglion, the oculomotor nerve, CN3 is there, inferior rectus, inferior oblique muscles, to the sphincter pupillae, to ciliary muscle, this nerve. Now, this is the optic nerve, this part, this is the diameter of the optic nerve. You see, again I go back to the previous slide. See the retina, the optic nerve head, choroid and sclera. Now, anteriorly separated from extraocular muscles by orbital fat, posteriorly annulus of Zinn, laterally ciliary ganglion, division of the third nerve and nasociliary nerve. This is the ciliary ganglion, and the the optic nerve, the lateral relation, and ophthalmic artery, superior ophthalmic vein and nasociliary nerve cross optic nerve from lateral to medial. Lateral to medial it goes there. Now, intracanalicular part, you can see enters the optic canal through the optic foramen, closely related to the ophthalmic artery, which crosses nerve inferiorly from medial to lateral side in the dural sheath, then leaves the sheath at the orbital end of the canal. Here, this is the optic nerve. The optic chiasma here. Enters the optic canal through the optic foramen, closely related to the ophthalmic artery, and which crosses the nerve inferiorly from medial to lateral side in the dural sheath, then leaves the sheath at the orbital end of the canal. See, this is the optic nerve here. The optic chiasma, the internal carotid artery, see the optic canal, 10 millimeter to 30 millimeter, and you can see the dural sheath here, subarachnoid space. Now, this is the total, the intracanalicular part. Now, intracranial part. Optic nerve with the intracranial part. See, it's a, this is the sphenoidal sinus. The sphenoidal bone lies above the cavernous sinus. This is the oculomotor nerve, trochlear nerve, abducens nerve, ophthalmic nerve, and this is the pituitary gland. Cavernous sinus is here, internal carotid artery. Peculiarities of the optic nerve: not a peripheral nerve but a prolongation of white matter of the brain. This is important. Not a peripheral nerve but a prolonged ophthalmoscopic examination. You get beautiful ophthalmoscope. This Chinese very good ophthalmoscope. You have it in your, when you go to the second year in medicine, you try to examine. Don't say refer to ophthalmologist. Dekhte kya? So you will see any book on medicine. You can see the 4 pictures, how the arterial network and the optic disc and the optic nerve is behaving. It is depicted. So you just do a ophthalmoscopic examination for your own interest, and you will find many clues. Then you send, and accordingly, your management will change, and you need the help of the your ophthalmologist. You give a call. In our days, Department of Ophthalmology was there, everything, but in the practice, you can go for an ophthalmoscopic examination. Now, myelination of optic nerve is derived from oligodendroglea and not from Schwann cell. This is important. The myelination of optic nerve is derived from oligodendroglea and not from Schwann cells. So, devoid of endoneurium and damage cannot regenerate. This is endoneurium and devoid of endoneurium. So, damage cannot be regenerate. It cannot regenerate. Optic nerve cannot regenerate. And the pile sheath carrying blood vessels projects into substance of the nerve, and this arrangement provides rich blood supply to the nerve. The pile sheath carrying blood vessels project into substance of the nerve, and this arrangement provides rich blood supply to the nerve. Now, the meningeal sheath of optic nerve. Intracranial part, pia, intracranial, intracanalicular and intraorbital, all three layers of the meninges. So the intracranial part is pia mater and intracanalicular, intraorbital, all three layers of the meninges. Now, dural sheath, subarachnoid and subdural spaces are continuous with that of the brain. Now, this is the retina, this is the central retinal vein, this is the dura mater, this is subarachnoid space, optic nerve, optic foramen, cranial subarachnoid space. This is a schematic diagram, beautifully illustrated, and it in relation with the meningeal sheath of the optic nerve, it can come as a short note. Now, peculiarities of the optic nerve, mainly supplied by pile network of vessels except orbital part of optic nerve. Optic nerve supplied by axial system derived from the central retinal artery. Pile network composed by internal carotid artery, middle cerebral artery, anterior choroidal artery, posterior cerebral artery, deep optic artery. It's the peculiarities of the optic nerve. Components of the optic nerve, special somatic afferent fibers for vision, afferent from pupillary light reflex and accommodation reflex, few efferents retinopetal fibers, for few efferents for retinopetal fibers, other connections of the optic tract, In addition to lateral genicular body, fibers from the optic tract also pass to suprachiasmatic nucleus of hypothalamus for controlling circadian rhythms, physiology, pretectal nucleus for control of fixation of eyes on objects of importance and pupillary light reflex, superior colliculus for control of bilateral simultaneous movements of two eyes, pulvinar forms secondary visual pathways, corpus callosum causes exchange of visual information between right and left hemispheres. This part is very important. Now the optic chiasma, the uncrossed temporal fibers and crossed nasal fibers. This is temporal. You see how the optic chiasma is being. This is the optic nerve. Now this is the optic chiasma, optic tract, posterior knee of Hornbilly brand. This is the interior nasal fibers, superior fibers, supratemporal fibers, infratemporal fibers. Optic tract winds around upper part of basis pedunculi and flattens out of the formed a small medial root and large lateral root. Medial root connected with medial geniculate body and forms fibers of Gooden's commissure through optic chiasma. Ventral supraoptic desiccation. The optic tract, macular fibers crossed and uncrossed occupy dorsolateral aspect of the optic tract, is the macular fibers. Upper peripheral fibers crossed and uncrossed medially situated, upper retinal fibers, and lower retinal fibers, lower peripheral fibers laterally situated. This is the Gooden's commissure. You can see the optic nerve and the crossed fibers in blue, and optic chiasma here, optic tract, commissure of Gooden, and pulvinar lateral geniculate body, superior colliculus. This is the medial geniculate body, the nucleus of oculomotor nerve, nucleus of trochlear nerve, nucleus of abducens nerve, and cortex of occipital lobes. This is the nerves going to the occipital lobes of the brain, the Gooden's commissure. That can be a short note in Gooden's commissure. You just see the components and how the crossover, the forming a chiasma, and the medial and nasal fibers, how it is going, and to the nucleus of the brain, to its in the brain, and the cortex of the occipital lobe. Now, lateral root, most of the fibers terminate in cells of lateral geniculate body for perception of vision. Some fibers sweep medially below pulvinar and of the thalamus and pretectal nucleus via superior brachium. They are concerned with pupillary light reflex and reflex for turning head and eyes to perceive a moving object. Few fibers terminate in the suprachiasmatic nucleus of the hypothalamus, forming retinohypothalamic tract. These fibers are connected to pineal body and mediate the influence of light and dark for circadian rhythm. Now, retinohypothalamic pathway. Retinohypothalamic pathway. This is the suprachiasmatic nucleus, lateral geniculate body, and see the right retina, the optic chiasma, and the left retina. This is the left retina, this is the right retina. Functional significance of optic tract. The genitocalcarian system is concerned with the perception of vision and solves the question, what is it? Tactile system, by reflex action, comes the eyes, head and neck to follow a moving object and answers the question where it is. Submammalian vertebrates, tactile system has dual role of visual perception and visio-motor reflexes. Mammals, consciousness of vision by visual cortex and visual reflexes by the tactile system. Tactum, the visual recognition. Now, ascending visual pathways, geniculostriate pathways from and detail, tectopulvinar pathway, motion and location. Both pathways start with the optic nerve leaving the eye. So, the ascending visual pathway, geniculostriate pathway, the optic chiasma crossover and selective attention, occipital areas, 17 simple cells, 18 complex cells, 19 hypercomplex cells. Temporal lobe, object identification. Tectopulvinar pathway, optic chiasma crossover, superior colliculus location mapping, occipital lobe 18 motion, 19 complex motion, temporal lobe combined visual information. These are the two ascending pathways. You chart, flow sheet. Now, retinogeniculate system. See the visual field of the eyes of the left, visual field of the right eye. Foveal area of both visual fields is the foveal area of the both fields. Projection on left retina. Now, you can see the optic nerve, the temporal hemiretina, nasal hemiretina, the optic tracts, lateral geniculate nuclei, primary visual cortex. This is the primary visual cortex. Now, input to lateral geniculate nucleus, input to right lateral geniculate nucleus. Now, input to primary visual cortex on the medial surface of the left hemisphere. Input to the primary visual cortex on the medial surface of the right hemisphere. This part. Now, if you given a section of a brain as a specimen and you are asked that what this area is, so you just visual field and retina, monocular visual field, bounded space of environment seen by one eye when that eye is fixed on a stationary point. Binocular field of vision, since normally we see with both eyes, there is almost a complete overlapping of monocular field of both eyes. This is actually when you are using the microscope, binocular microscope, you just today, if you go to the histology lab, then you will see when you are viewing the slide, then slowly when you scan the slide and then the focus comes. Previously you will see one eye, two eyes, and then you will see two eyes. Then you will see it overlaps and you can see the total field of the area focused by your microscope. Now, monocular crescent most lateral peripheral areas of visual field are seen by one eye only. Retinal quadrants. Yeah, this is what I was speaking. The retina, as you would see it through the ophthalmoscope and patient's pupil. This is the upper temporal quadrant, lower temporal quadrant, upper nasal quadrant, lower nasal quadrant. The blind spot in the visual field corresponds to the location of the optic nerve head on the nasal side of the retina. So, when you see the macula fovea here in the center and see the blind spot in the visual field corresponds to the location of the optic nerve head on the nasal side of the retina. So, when you are doing an ophthalmoscopy, then you try to visualize the nasal side, then you will see the blind spot. And you will see if it is hypertensive, diabetes by the arterial structures of the retina. Visual field and retina. The nasal half of the field of vision of each eye is smaller than its temporal half because of the shadow of nose. Right half of the field of vision of an eye is projected to the left half of retina, left hemiretina, and left visual field to the right hemiretina. Field of vision of an eye or retina may be subdivided into quadrants by two meridional lines, horizontal and vertical, intersecting in the middle of the macula. Thus, upper nasal quadrant of the field of vision is projected to the lower temporal quadrant of retina. The iris, this is the pupil, this is the fovea here, and this is the blind spot. Rods and cones, this is the whole of retina, and optic nerve. Nowadays, actually, OCT imaging, optical coherence tomography of the retina. Every good center in ophthalmology and the ophthalmologist, before going for an operation, or you are saying that you are having some problem with your vision, or all of your father is hypertensive or diabetic retinopathy and hypertensive retinopathy. Sometimes all of a sudden there is blindness due to diabetes, diabetic retinopathy and hypertension. And this can be how much severe is the retinal detachment only can be gauged with optical coherence tomography. That's an imaging tool, and highly you can see any this thing, your optical coherence tomography report. Even yourself, you can see the retina, and if there is any problem, that is even sorted out and indicated. Now, this is the visual field. This is the retina here, and the optic nerve, this is the optic chiasma, and lateral geniculate body here, and is the optic radiations, and this is the visual cortex. The optic nerve, optic chiasma, optic tract, lateral geniculate, nucleus of the thalamus. এগুলো তোমরা মানে visual field you have to practice these diagrams, because you can come as a 10 marks question or full question. Don't neglect optic nerve as such, কারণ এটা আসতেই পারে তোমার। এগুলো সব বইয়ে পাবে, কিন্তু তোমরা ডাউনলোড করবে যেখান থেকে হোক, যাই থাকুক তোমার যে বইটা। ডোন্ট ট্রাই টু গো ফর এনি নিউ বুকস অর নিউ দিস থিং। কেউ বলছে যে এটা নিহারি ভালো বলছে, আবার ঝট করে নিহারি লোড করতে লাগবে। এ বলছে যে শিবানী মজুমদার ভালো বলছে। ডোন্ট ক্র্যাম, ডোন্ট ওভার ক্রাউড ইয়ার। তোমার যেটা পড়া আছে সেটার সঙ্গে একটা দুটো ইনপুট যদি মনে হয় তুমি নেবে, তাহলে নেবে। এই 1.5 মাস এখন মানে ছন্ন ছাড়া থাকবে না। বি ফোকাসড একদম, মানে বসে বসে ছবি আঁকো। যেমন ঘুম পাবে রাতে 11টার সময় রিভিশন করবে, 10টা থেকে লাঞ্চ ডিনারের পরে, এদিকে বিকেলের দিকে সন্ধ্যের দিকে বায়োকেমিস্ট্রি, ফিজিওলজি একটা ভালো তোমরা রুটিন করে নাও। আর রাতের দিকে 1 ঘন্টা রাখো মানে ভাইবা, অ্যানাটমির ভাইবা amongst yourself, 4 boys, 2 of you, your roommate. এটা করো, দেখবে তুমি রেজাল্ট পাবেই। আর রাত 2টো 2:30টা পড়েছে, ল্যাদ খেয়ে গেলে 8টার সময় ব্ল্যাক কফি খাবে, ডোন্ট ডু ইট। your brain absorbs or productive is Brahma Muhurto from 4 a.m. to 8 a.m. 99%। তুমি যা নেবে, যা বলবে, যা থিঙ্ক করবে, সেটা তোমার হবে। এটা ফলো করো। 1.5 মাস 1 বছরে হয়নি ফলো, ইউ ফলো আপ দিস, ওকে। নাও ভিজুয়াল fields. The monocular crescent of the left eye, monocular crescent of the right eye, binocular vision, visual field. Now retina of the right eye, left retina. The image of an object in the visual field is inverted and reversed right to the left on the retina. Temporal field of the left eye, red and purple, is seen by the nasal retina of the left eye. Nasal field of the left eye, green and yellow, this is seen by the inferior retina of the left eye. Inferior field of the left eye, purple and yellow, is seen by the superior retina of the left eye. Similarly, the image is inverted and reversed for the right eye. Now, eye examination. Eyes are the windows to the brain. The visual acuity of the eye, CN2 and beyond in the visual pathway. Visual fields, central and peripheral vision, retina to cortex. Ocular motility, C3, C4, C5, 6. Reflexes, pupillary light reflex, C2 and 3. Accommodation near reflex. Corneal reflex, C5 and C7. Retina including optic disc, increased intracranial pressure, status of blood vessels reflecting hypertension and diabetes that I have been discussing with you. So this is the, means it can come as a short note. The eye examination means the acuity of vision, visual fields, ocular motility, reflexes, the pupillary light reflex, the accommodation reflex, retina including optic disc, increased intracranial pressure, status of blood vessels, reflecting hypertension and diabetes. Now, the visual pathway, since it is precisely organized and extends from the rostral to caudal aspect of the hemispheres, lesions along the pathway produce specific deficits that can aid in localizing the lesion. But if you see the from the optic disc retina, the optic nerve and the visual pathways, its crossover of the chiasmata, and you can see at what level the lesion is. এখন সব মাথা থেকে উড়ে যাচ্ছে কারণ তোমাদের ফার্স্ট ডে I welcome to you in the class. Next year you will be sitting for exam in August. আজকে তো এখনো তো কাউন্সেলিং চলছে তোমাদের ব্যাচে, তাই তো? এই আজকে তো আলাপ হবে। Lesions of visual pathways, এগুলো just একটু now lesions of the optic nerve characterized by marked loss of vision or complete blindness on the affected side associated with abolition of direct light reflex on the ipsilateral side and consensual contralateral side. Causes optic atrophy, indirect optic neuropathy, acute optic neuritis, traumatic avulsion of optic nerve, example right optic nerve involvement. Lesions of the visual pathway, this can come as a question. Lesions to the proximal part of the optic nerve. The ipsilateral blindness, contralateral hemianopia, abolition of direct light reflex on affected side, and consensual light reflex on contralateral side, near reflex intact, right optic nerve involvement in proximal part. Now, the anterior chiasmal lesion affects the ipsilateral optic nerve fibers and the contralateral infranasal fibers. Ipsilateral optic neuropathy manifested as a central scotoma and a defect involving the contralateral supratemporal field, also known as the junctional scotoma. Abolition of direct light reflex on the affected side, consensual light reflex on contralateral side, near reflex intact. Central lesion of the chiasma characterized by bitemporal hemianopia, bitemporal hemianopic, paralysis of pupillary reflex leads to partial descending optic atrophy. Causes suprasellar aneurysm, tumors of the pituitary gland, craniopharyngioma, suprasellar meningioma and glioma of third ventricle, and third ventricular dilatation due to obstructive hydrocephalus, chronic chiasmal arachidonitis. Now, the central lesion of chiasma such as the bitemporal hemianopia, bitemporal hemianopic, paralysis of pupillary reflex, usually leads to partial descending optic atrophy, causes suprasellar aneurysm, tumors of the pituitary gland, craniopharyngioma, suprasellar meningioma and glioma of the third ventricular dilatation due to obstructive hydrocephalus, and chronic chiasmatical arachidonitis. You are seeing a CT scan brain, then CT scan brain, if any distortion in the ventricles, and also complaining of some eye problem, আমার এই রিফ্লেক্স গুলো, so this can be that's a lesion in the third ventricle, tumors of the pituitary gland. Lateral chiasmal lesion is binasal hemianopia, binasal hemianopic, paralysis of the pupillary reflex, usually lead to partial descending optic causes of the third ventricle causing pressure on each side of the optic chiasma. So, atheroma of the carotids and posterior communicating artery. Posterior chiasmal syndrome, macular fibers cross more posteriorly in the chiasma, Paracentral bitemporal field loss. Posterior lesion may also involve the optic tract and cause a contralateral hemianopia.